clinical symptoms, positive skin testing, and histopathology evidence or chemical evidence of supporting the diagnosis of TB, as well as microbiology. Sometimes you get culture positive. And differentiation always comes, this differential diagnosis differentiating between inflammatory bowel disease and abdominal TB. It's always a challenge. And if diagnosed early and treated properly, usually the outcome is very good. And the treatment has published many studies ranging from 9 to 12 months. And in general, usually we start by 4 anti-TB in the intensive phase. Then we, of course, based on the culture result, if there is culture result, continue the cultivation phase about 7 to 9 months with the 2 drugs. So this is the end of my presentation. Thank you very much for listening.
Thanks to Dr. Usman Jum'a, and we would like to welcome Dr. Abdulrahman AlRasheed, talking about sarcoidosis and also Behçet disease as mimical for IBD. Dr. Abdulrahman AlRasheed is a consultant pediatric rheumatology and pediatric consultant and fellowship director in King Abdullah Specialized Hospital, KASCH Center in King Abdulaziz Medical City, Ministry of National Guard in Riyadh. Dr. Rashid, the mic is yours, please.
Thank you very much, Dr. Muhammad, for your kind invitation and introduction. So I would speak about sarcoidosis and Behçet disease as a mimicker of inflammatory bowel disease. My objectives from this presentation to recognize similarity and differences between Behçet disease and inflammatory bowel diseases, especially Crohn's disease, and to understand the overlapping features between also inflammatory bowel disease and intestinal sarcoidosis. So this is outline of my presentation. So I would present a case that I face myself of Behçet disease versus Crohn's disease, because I diagnosed it as Behçet disease and my colleague in gastroenterology diagnosed it as Crohn's disease. And this is also the same problem happening in the literature. Then review of Behçet disease, then similarity and differences between Behçet and Crohn's disease. Then we'll move to the sarcoidosis with a case presentation of sarcoidosis versus Crohn's disease. Also another patient that I face myself. Review of intestinal and extra-intestinal sarcoidosis. So the first case is a 10-year-old girl. She presented at the age of 7 years with recurrent oral and genital ulcer along with fever and watery diarrhea for 7 months. She had recurrent pustular skin rash. And this is, we do see it in Behçet disease. Seen by gastroenterologist at a local area, and the scope was done, which was not suggestive of inflammatory bowel disease. I spoke with him myself. He said just scattered ulceration, but it's not typical of inflammatory bowel disease. Unfortunately, biopsy wasn't taken during the scope. Skin biopsy done and revealed perivascular infiltration by lymphocytes with a picture of lymphocytic vasculitis. And this is a kind of typical histopathology where we see it in Behçet disease. This is her picture of the, probably you could appreciate the pustules at the dorsum of the foot. She has foot swelling due to low albumin. The same thing at the plantar surface of the foot. And there is here also picture of folliculitis with some necrosis. And this has been described very well in patients with Behçet disease. So this patient was treated with a steroid and tapering course over 2 months. She started to have right thigh swelling. Ultrasound revealed deep vein thrombosis in the right iliac and femoral vein. They did echo and it showed massive echogenic mass obstructing left pulmonary artery. Diagnosed, then she was transferred to our hospital. And we find the picture is consistent with Behçet disease. So we treated her with high-dose steroid, methotrexate, and infliximab. However, she had a reaction to infliximab. Then we shifted to adalimumab along with low molecular weight heparin. After a few weeks, there was a complete resolution of the left pulmonary artery thrombosis, and all her manifestations have resolved. In fact, this is what we do also see in Behçet disease. Behçet disease thrombosis is secondary to vasculitis. It's inflammatory thrombus. So if you treat with anti-inflammatory, this may cure the thrombosis. And there is in fact controversy about using heparin in those cases, because people, they do not believe it would be helpful. So here you could see in the CT line the organized thrombosis obstructing the whole left pulmonary artery, the left main pulmonary artery. And this is after treatment. This is the right and this is the left, where you can see there is no more thrombosis. So she was treated with adalimumab for almost 2 years, then tapered and stopped, and this is what we do in those diseases. Then ultimately afterwards, by a few months, she started to develop a bloody diarrhea with significant weight loss. There was no skin rash or joint pain. However, at this time, PR examination showed skin tag and fistula. ESR was high, as well as C-reactive protein and low albumin. Seen at this time by my colleague in gastroenterology, and they did MRE, large bowel showed circumferential mural wall thickening involving ascending and transverse colon, and the post-contrast showed enhancement with the mucosal ulceration with a picture of cobblestone pattern. The same thing for small bowel, circumferential mural thickening of the terminal ileum with fissuring ulcer giving a cobblestone pattern. Her upper endoscopy was normal. The colonoscopy showed pancreatitis with pseudopolyp and exudate. And the biopsy showed chronic active colitis, cryptitis, and crypt abscess. However, no definitive granuloma. And this is the picture of her scope with pseudopolyps. So whether this case is Behçet disease or inflammatory bowel disease, namely Crohn's disease, in fact, it's very difficult to tell. And in the literature also, there is overlapping features. But the good thing that the treatment almost the same. Just to review about Behçet disease, it's a systemic vasculitis that could affect any blood vessel size. So this is the only type of vasculitis that could affect any size of blood vessels and could affect vein and arteries. It has a unique geographical distribution around the historical Silk Road. So you could see that this is the area where Behçet disease is common. In our area, probably in the northern part and also in the Jordan and Turkey. It was described initially by Hulusi Behçet, a Turkish physician in patients with recurrent oral and genital ulceration and uveitis. It's mainly affecting adults, and the juvenile cases account for almost 20%. The mean age of onset in children in the literature ranging from 5 to 12 years, and equally in children affecting male and female, while in adults it's mainly a male disease. Diagnosis usually after 3 years of onset of the symptoms. And the pathogenesis is not really well understood. However, infection or environmental trigger in a genetically susceptible person, probably this is what I mean, the accepted theory. Some patients, they have a predilection for HLA-B51. However, HLA-B51 found in normal people in 10 to 15%. So its diagnostic utility is really controversial. In the GWAS study, there is some genetic locus were linked to Behçet disease like IL-23 receptor, IL-10, and STAT4. Also, what supports the genetic is familial aggregation, or some cases they aggregate in the same family. There is a new autoinflammatory disease which fulfill the criteria of Behçet disease and resembling Behçet disease with recurrent oral and genital ulcer as well as skin manifestation. It's the haploinsufficiency A2, where there is a mutation which leads to activation of NF-kappa B and ultimately release of tumor necrosis factor alpha and interleukin-1. And they found it high in those patients, and they respond very well to either anti-TNF or anti-IL-1. This is the criteria of Behçet disease for children, recurrent oral ulcer, at least 3 attacks per year, genital ulceration or aphthosis, typically with a scar. However, in children, probably the scar is less pronounced. Skin involvement, it could be ranging from necrotizing folliculitis, acneiform lesion, erythema nodosum, and the ocular involvement, anterior or posterior uveitis or retinal vasculitis. Some patients, they may present with neurobehçet with various presentation, with the exception, so it's one of the criteria with exception of isolated headache. And vascular also involvement, venous or arterial thrombosis or arterial aneurysm. The clinical manifestation of Behçet disease, the common is a mucocutaneous lesion, oral ulcer happening in vast majority of the patient, and usually is very painful, multiple, and non-scarring. The genital ulcer happening in 60% and usually is a scarring and involving scrotum, like in this picture, and labia in females. The other cutaneous finding, erythema nodosum, papulopustular lesion, folliculitis, maybe with necrosis, like our patient, or acneiform lesion, and though pathology phenomena also is a recognized phenomena happening in Behçet disease. However, it's not a pathognomonic. The pathology phenomena, when you just inject an empty needle, within 48 hours, you would see a skin reacting in form of pustule or nodule. Musculoskeletal finding happening in 40% and usually affect lower limbs, usually self-limiting and non-deforming. And there is also involvement of the sacroiliac. If you notice, probably this is also the same for inflammatory bowel disease. Eye involvement, it could happen within a few years after the diagnosis, and typically it's a bilateral posterior uveitis, but panuveitis or anterior uveitis with hypopyon can happen. Neurological involvement, either parenchymal or non-parenchymal. In parenchymal, usually typically affect brainstem, basal ganglia, sometimes spinal cord or cerebral white matter. And non-parenchymal, it's mainly vessel involvement, and it involves the cerebral venous vessels with the thrombosis and pseudotumor cerebri. The vascular involvement, it involves all size and types of blood vessel. Venous system is more common, and the most common is lower extremity venous thrombosis, especially the iliofemoral, like what happened in our patient. Some patients, they may have thrombophlebitis. Patients, they also may have pulmonary artery aneurysm, and this is the most common cause of mortality, and thrombosis in the pulmonary artery can also occur. Now I will concentrate on intestinal Behçet because it's really confusing to the inflammatory bowel disease, and sometimes it's difficult to differentiate between two. The frequency varies from 4 in Turkey to 30 in USA to 50% in Japan. Underlying pathology is lymphocytic vasculitis affecting vein, especially the small venule, and which cause inflammation and ulceration. The clinical presentation depends on which mesenteric blood vessel and bowel segment were affected. Commonly, intestinal Behçet, like Crohn's diseases, affect terminal ileum and cecum with rare colonic and anorectal involvement. It can cause GI inflammation, ulcer, bleeding, stricture, and also perforation. There is less than 100 cases reported in the literature with perforation, especially at the terminal ileum, and also fistula. Rarely, perianal involvement can cause proctitis, rectal ulcer, fistula, fissure, and abscess. The CT enterography, it may show bowel wall thickening, mural edema, with ulcer penetration or tumor-like polypoid mass that showed marked mural hyperenhancement. And the MRE may show bowel thickening with polypoid appearance and restricted water diffusion. On endoscopy, patients typically have scattered, irregular, discrete, round to oval shape, punch out large ulcer, large deep ulcer more than centimeter, and also other description of volcano ulcers are, which is a deeply penetrating ulcer with nodular and fibrotic margin, has been well described in the literature. The characteristic pathological finding include terminal ileal involvement with lymphocytic venulitis, deep and longitudinal ulcer with overhanging ulcer edge and collar pattern. medical treatment, it resembles that for Crohn's disease. And if there is any intestinal involvement with Behçet, it's the same as almost Crohn's disease, with sulfasalazine, 5-aminosalicylic acid, corticosteroid, immunosuppressant, especially azathioprine, tacrolimus, or biological therapy like anti-TNF alpha monoclonal antibodies. Surgery also is reserved for patient refractory to medical therapy or those who have complication like perforation, fistulation, or obstruction, or severe GI bleeding. Stomal formation is preferred over primary bowel anastomosis at surgery because of high risk of GI complication, such as anastomosis leak. And disease may occur in 40 to 80% in patient post-operatively, commonly at the anastomosis. This is just to show you that also thromboembolism can happen also in inflammatory bowel disease, especially in Crohn's disease, and especially in ulcerative colitis, especially with the disease activity. And commonly it involves venous system, especially the lower levels. Here there is some differentiation between Crohn's and Behçet's disease. So the clinical manifestation, sometimes it may mimic each other. However, Behçet's disease, they may have more genital ulcer. Extraintestinal manifestation, almost they have the same. Histological features, usually in Crohn's disease, it's a granulomatous disease, while in Behçet's, it's a vasculitis. And there is also some genetic predisposition, like in Crohn's disease, not to, and we will come to this when I speak about sarcoidosis, while in Behçet's disease, HLA-B51. And the therapy almost the same, and the surgery for refractory cases in both. This is again another just to explain the similarity between the two. Both of them, they may have oral aphthous ulceration, uveitis, erythema nodosum, peripheral arteritis, sacroiliitis, and gastrointestinal symptoms. However, the treatment is the same. Behçet's disease, they have probably genital ulcer more, with a scar, some skin manifestation different from Crohn's disease, and also pathergy. However, pathergy has been mentioned in patients with Crohn's disease, and plus the aneurysms and thrombosis. On the other hand, the Crohn's disease, they have episcleritis, conjunctivitis, more of a perianal fistula or fissure, more of pyoderma gangrenosum, Sweet syndrome, and they have positivity for ASCA. Despite this, also ASCA has been also reported patients with Behçet's disease, and it's an glomerulous disease. This is also to show the differences between the two, where perianal is more in Crohn's disease. This is just looking for biomarkers, where the utility of apoptosis inhibitor of macrophage as possible diagnostic marker in patients with Crohn's disease, and they found it high compared to patients with Behçet's disease and ulcerative colitis. So those patients, they have apoptosis inhibitor, and this leads to persistence of macrophage with the persistence of the inflammation. The second, I will go briefly on sarcoidosis.
3 minutes left.
Okay, so this is another case, 13 years old boy. His illness started at the age of 6 years, where he presented with lip swelling, recurrent hemifacial soft tissue and right eye swelling, with 7-month history of abdominal pain, weight loss, and loose stool. In examination, he has picture of lip and gingival swelling, where this is the picture of orofacial granuloma, with generalized lymph node enlargement and splenomegaly. Upper and lower endoscopy were normal. He had normal labs, just high inflammatory markers, normal ACE, and the quantiferon was negative. He had positive P-ANCA, and oxidative PERTS was normal. Lymph node and GI biopsy all showed non-caseating granuloma. So we labeled him as sarcoidosis after discussion with our colleague in gastroenterology. Treated with adalimumab and methotrexate with good response. He went to UK for another opinion, and he came with a diagnosis of Crohn's disease. He had allergy to methotrexate and adalimumab, and then we tried him on different modalities, but without response. Then ultimately his calprotectin was very high, and our colleague in gastroenterology, they did another scope which revealed terminal ileal mucosa with focal active inflammation and colonic mucosa with granuloma. So this probably our colleague gastroenterologists thought about Crohn's disease. We did WES and BID panel, and we found a variant of unknown significant in BAC2, which is linked sometimes to immune deficiency and inflammatory bowel disease. However, whole genome sequencing was negative. So at this time, he was diagnosed with Crohn's disease and started vedolizumab for treatment with diet and cinnamon, and he did well afterwards. Sarcoidosis is a multi-system disease characterized by presence of the non-caseating granuloma. It has two main clinical presentations. Children less than 5 years, they have a triad of arthritis, rash, and uveitis, but in older children, like in the adult, where they have mainly pulmonary involvement. Any organ can be involved in sarcoidosis: skin, CNS, bone marrow, eye, bone, joint, or kidneys. The liver is the most common extrapulmonary involvement, and the stomach is the commonest site in the alimentary tract and result in gastritis, gastric ulcer, or erythema and friability. Alimentary tract involvement, it happens in less than 1% and can affect any part. However, the stomach is the commonest. Orofacial granuloma also can be cause of sarcoidosis. That's what makes us confused with that case. Labs may show anemia, leukopenia, thrombocytopenia, high ESR, high calcium, high ACE, elevated liver enzyme, low albumin, or hypercalciuria, with elevation also of CD4 over CD8. CT may show nodular lung lesion, a large lymph node, pleural effusion, or hypodense enhancing liver lesions. And the endoscopy may show erosive hemorrhagic nodular gastric mucosa. Colonoscopy may be normal, like in our patient, but the biopsy will show the granuloma. Or may show ulcers and erythema, and the biopsy is the gold standard for diagnosis of sarcoidosis, and it showed epithelioid non-caseating granuloma. And the diagnosis based on exclusion other diagnoses like Crohn's disease and tuberculosis. This is a case reported by our colleague in King Fahd Medical City, pediatric gastrointestinal sarcoidosis, where they successfully treat those patients with anti-TNF infliximab. They reported 2 cases, both of them with gastric involvement and liver involvement, and they did well on anti-TNF. Here, just to show you the confusion in the literature, sarcoidosis can cause granulomatous enterocolitis. Here to show you the confusion in the literature, where this sarcoidosis of Crohn's disease, or in other reported cases, improvement with infliximab of a disseminated sarcoidosis in patient with Crohn's disease. So they are not sure which is which. There is a monogenic form of sarcoidosis and inflammatory bowel disease caused by NOT2 mutation. NOT2 is an intracellular signaling where it detects pathogen or danger recognition pattern. This is the protein of the protein of the node, where it has card and leucine-rich residue on the other side, and NACHT at the center. Here, most of the mutations were affected in sarcoidosis, while Crohn's disease, it affects usually the leucine-rich residue. And this is those patients with the Crohn's disease, they usually present with perianal manifestation, while the sarcoidosis, they present with arthritis, uveitis, or skin manifestation. So in summary, Behçet's disease and sarcoidosis need to be included in the differential diagnosis of patients with inflammatory bowel disease, especially if they have extraintestinal manifestation. Overlap can happen that makes the exact diagnosis very difficult, and biomarkers are needed to guide the diagnosis. And thank you very much for your attendance.
Thank you, Dr. Rashid. Our next speaker is Dr. Afnan Al-Jawad. She's a final year fellow from King Faisal Specialist Hospital in Riyadh. She will talk about basidiopolymycosis as a mimicker of IBD.